Some of the newer drugs finish this chapter. The thiazolidinediones are a group of drugs that we often refer to as the glitazone, with pioglitazone and rosiglitazone as members. You want to know thiazolidinediones for a couple things. First, it has thia in the name. Thia means it has sulfur. Sulfur means potential for allergy, lipid solubility. Azole is also in that name. Never forget, with azole you can always run the risk of potentiating the effect of alcohol. Dindiones, I don't care about that part, just the beginning. What these drugs were developed for is literally for what we think metformin was doing 50 years ago already, which is to bind to those transcription factors we call PPARs. By the way, it stands for peroxisome proliferator activated receptors. Well, with a name like this, you can have a sympathetic response. So PPARs is certainly plenty enough. And those PPARs are involved in transcription of insulin-responsive genes. So the whole idea, again, is to bypass the actual insulin receptors and allow tissues to have an insulin-like response in the notable presence of a drug stimulating PPARs rather than insulin through its transduction pathway. As a result, for example, gluconeogenesis will shut down. Indeed, remember, insulin has effect on that pathway. It has effect at several levels. Directly, it can cause dephosphorylation of the fructose 1,6-bisphosphatase, and if you dephosphorylate this enzyme, it no longer works. Glucagon turns it on through the actual phosphorylation. As a matter of fact, let me repeat this. For gluconeogenesis, remember that insulin actually will result in inactivation of the rate-limiting step fructose 1,6-bisphosphatase. It does it indirectly through the levels of fructose 2,6-bisphosphate, so that as PFK2 is turned on by insulin and makes fructose 2,6-bisphosphate, let's remember that this is the allosteric activator of PFK1 of glycolysis. So in presence of insulin, high fructose 2,6-bisphosphate stimulates glycolysis and glucose breakdown. At the same time, the same fructose 2,6-bisphosphate inhibits the rate-limiting step fructose 1,6-bisphosphatase of gluconeogenesis. Indirectly, otherwise, there are effects through PCK, the rate of fatty acid oxidation, and so forth. So, decreased gluconeogenesis. There will also be increased insulin receptor numbers thanks to these PPARs. There's a big story with those thiazolidinediones. They cause certainly far less hypoglycemia than sulfonylureas. As a matter of fact, pretty much you get hypoglycemia if you use them as adjunct to sulfonylureas, but they will result in weight gain and potential edema in the patient. Here's a diagram reviewing the mode of action of these classic diabetes drugs. This is your blood. This is the glucose that you're trying to make disappear into tissues. One way would be to prevent its entry in the blood by working in the gut. Starches are broken at some point by alpha-glucosidase. This is where acarbose inhibits this enzyme and decreases postprandial glucose. Otherwise, we could work on the pancreas and increase the insulin production. This is what oral sulfonylureas do. Also, a drug called repaglinide increases insulin secretion. It's not an OSU, but it works in a similar fashion. Or we can try and make the glucose disappear in a more biochemical way. Drugs like glitazones and metformin bypass the insulin receptors and through PPARs inhibit the production by the liver through shutting down gluconeogenesis and enhance the uptake, particularly through the GLUT4 transporter in skeletal muscle.